Welcome, everyone. Again, my name is Carol Boxta, and this is the Oral Abstract Session B. I will be co-moderating today with Samantha Montoya, and we have some amazing presenters today that we will go ahead and begin. Before that, Samantha, do you want to do a quick introduction?
Sure thing. Hi, y'all. My name's Samantha Montoya. I'm a research coordinator at Moffitt Cancer Center working in colorectal cancer prevention research. Glad to be here.
And same as Samantha, I'm also at Moffitt Cancer Center working as a research coordinator as with the University of South Florida MPH program. All right, so we will go ahead and get started with our first presenter. Federico Israel, if you want to go ahead and share your screen.
Thank you very much. Let me try to share my screen.
And I will be sending you a message just to let you know when it's about 5 minutes that you have left for your presentation.
Okay.
And please save any questions. Once you finish this presentation, we'll go ahead and go into questions. Thank you.
I just would like to make sure that you can see my screen.
Yes, do you want to put it in presenter mode? Perfect.
Yeah, about now?
We can see it.
Great. Hello, everyone. My name is Federico Epalang Albano Israel. I'm originally from Angola, but I've been in Hungary for 10 years. So I live in Budapest, and I'm at the University of Budapest in Debrecen, in the Faculty of Medicine, the Department of Public Health and Epidemiology. So I'm working on health literacy, especially in communicative health literacy. And in today's presentation, I'm going to talk about the association between health status, behavior, and communicative health literacy based on the Hungarian nationwide survey. So as an introduction, first of all, I would like to start defining communicative health literacy based on the consortium network, which is the European National Consortium. So communicative health literacy has been defined as social and communicative skills that enable the person to interact with the healthcare professional in the healthcare services, and not only to ask questions, derive meaning for that, in co-production of they are healthy. So based on the importance of the communicative health literacy, the field has gained quite a significant research point, not only as a public health subject, but also specifically for the health promotion. So the objective of our study was to basically to describe the communicative health literacy of the adult Hungarian population and to investigate the association between the health status, behavior, based on the survey, the national-wide surveys, as I said from the beginning. So from the methodological point of view, our study had a total of 1,205 Hungarian adults aged 18 and older who completed the telephone interview as part of the International Health Literacy Survey 2019. So our questionnaire included different items. Among those, we had items on social demographic data, health status, health behavior, and communicative health literacy. So to ensure that the estimate reflects the general Hungarian adult population by age, gender, education level, and settlement status, statistical weights were applied. And also to find the association between our variable, a binary logistical regression was used. So as we can see here, we have the communicative health literacy items, and on the top here, we can see the scales that we used to measure the communicative health literacy. And as we can see here on the chart, Below, we can see the items. We use the short version of the communicative health literacy. And on the left side, we can see this question that is highlighted now with a red star, which means that was the most difficult item. And on the right side, we can see the item highlighted on the green star, which means was the easiest item among the participants. So here we can see the average percentage of the respondent pattern, which means that the colors already tell us what does it mean. We can see that about 21% of our participants, they could answer the question to be very easy. And we can see here 65% was easy for them. And altogether, the very difficult one, when we combined, we found that about 13.3% of the participants, they had problems of communication in the healthcare services. In the next one, we can see the association between our variables. And as we can see here, all the items that are highlighted in bold were our positive value, or those ones with positive value. So here we cannot argue or completely say that those variables that are not highlighted are not associated with the communicative health literacy, but in our study we didn't find any positive value. Therefore, as we can see, the limitation by health problem was very much associated with the level of communicative health literacy, as well as the everyday physical activity, daily fruit and vegetable consumption. So, in our conclusion, we found out that nearly 1/8 of the Hungarian adult population had difficulties during communication in the healthcare service, and also individuals with high level of communicative health literacy, they showed to have lower odds of limitation by health and the higher odds of everyday physical activity, daily fruits and vegetable consumption, which means that those people, in simple words, those people who had a higher level of communicative health literacy, they had less problems with their health, or also we can say they had less complaint or better health compared to those people who had less or lower level of communicative health literacy. Also, we conclude that a high level of communicative health literacy could contribute to a better health status and health-related behavior, because we found out that people with the higher level of communicative health literacy the person had, more health behavior and status the person had based on our results. So, as our recommendations, first of all, based on our results, we found that there are more than 13% of people who present or shows to have a problem during communication with the physician or healthcare professional. Therefore, we recommend to improve people's communicative health literacy in general. Also, we recommend to enhancing the effectiveness of communication, improving the communication skill, not only the patient or healthcare visitor, but also the healthcare professionals. And there is also a need to facilitate the communication among healthcare users through environmental change, for example, by employing more health educators in the healthcare service. So thank you very much for your attention. And that was all about what I wanted to present today. Thank you very much.
Great job. We'll go. We have about 5 minutes. If anyone has any questions, please feel free to unmute yourself or to write it in the chat. I think one question that I could ask is if the capabilities are there for health educators, how would their role look like in increasing this health communication, health literacy?
Well, for example, there is already an experiment here in Hungary. One of them could be to introduce the communicative health literacy as a extracurricular subject, if it's possible, in not only in health sciences, but in most of the school, and also in every hospital, where in some countries, for example, it already works. Every single day, from Monday to Friday, for those people who go to seek for the healthcare provider, before they enter the consultation, there is a meeting about 15 minutes where a healthcare educator can give a speech about a certain topic or about health in general, or how they could improve the communicative health literacy. So those are some of the ideas that could be addressed. But other ones could be developing more, for example, flyers that even people with problem with speech, for example, they can at least see what the flyer could tell, what they could learn from that. And we could see, for example, during the COVID-19 pandemic, that we had the flyers with the orientation how, for example, we could wash our hands correctly. So those could be one of the strategies. Thank you.
Thank you. Great response. And we have another question that came in. Did you find specific populations have better or worse communication health literacy?
Yeah, actually, in Hungary, there are, we have how can I say, the general population, Hungarian population, and the minority. So there is a study that we try to compare how the health literacy would really differ, and we studied specifically the minorities, the Hungarian minority, how the health literacy and the communicative health literacy would be or is compared to the general. So we don't have the results yet, but there is an ongoing study for that particular community.
Interesting. All right. Anyone else have any other questions? I think you're good. All right. Thank you so much. Again, for great presentation. And we're gonna go ahead and jump over to our next presenter, Joseph Dean. If you could please share your screen.
Sure. Okay. Can everyone see?
Yes.
Okay. Good afternoon, everyone. I'm Joe Dean, a project coordinator at LSU Health. Shreveport, and I work alongside of Doctors Connie Arnold and Terry Davis. The topic today will be health literacy strategy to promote longer-term adherence to colorectal cancer screening among underserved population in the rural health clinics, the PRIME CRC trial. This is my funding disclosure, and colorectal cancer is the third most common cancer and the second leading cause of cancer death in the U.S. And Louisiana ranks fourth in the U.S. for colorectal cancer incidence. Here, as you can see, colorectal incidence rate are higher in Louisiana compared to the US rates in all groups. Screening disparities, risk factors for poor colorectal cancer screening adherence with low socioeconomic status, low health literacy, minority race or ethnicity, or rural locality. We conducted studies in federal qualified health clinics. Government-supported clinics provide services to more than 30 million, regardless of insurance status. All states, over 9.6 million rural residents were served by FQHCs in 2022. 30% rural, 63% belong to racial and ethnic minorities. We offer two types of screening. Here is the fecal immunochemical test, the most sensitive FOBT, proven effective for the early detection of cancer, more cost-effective, easier to use than traditional FOBT, less restriction and simpler instructions, and patient doesn't have to take off from work. They can do it at home. The second is the colonoscopy, which is considered a golden standard screening test which identifies approximately 95% of colorectal cancer. Colonoscopy is the most common used colorectal cancer screening test in the US. It is also the only method that allows gastroenterologists to both detect and remove potential precancerous colon polyps. And this test is good for 10 years if the doctors don't find any problems. This is a 5-year randomized controlled trial in 6 rural FQHCs to test the effectiveness of prime CRC intervention to improve colorectal cancer screening completion rates in rural FQHCs compared to enhanced usual care. Investigate whether prime CRC strategies can reduce CRC screening disparities by patients' health literacy, race, or sex. Yeah, the study sites are within 6 North Louisiana rural community clinics, which is your hair colorectal cancer screening 17% at 38% rate, and 65% African Americans, 61% females, and 38% less than 9th grade reading level. For enrollment of patients, they are screened for eligibility and consented, administered CRC survey and literacy screening tests, screening recommendation given for CRC screening, and discusses importance of CRC screening. The research assistant also works with the patient using shared decision-making to choose screening methods that the patient feels is best for them. And if the patient chooses the fit, the research assistant will give them a simplified fit instruction along with a fit kit and then demonstrate how to do the fit kit. And if the patient chooses colonoscopy, then the research assistant will give them simplified colorectal cancer prep instruction, and then the clinics will schedule their appointment for the colonoscopy and pre-assign randomization. If a randomized to intervention, the research assistant goes over the automated calls or text messages they will receive based on screening method they choose. Methods for the intervention arm. The patient will receive frequent follow-up and motivation reminders, messages via automated call or text from a provider at the clinic to complete the fit kit if they have not returned it in 4, 8, or 12 weeks. And when a colonoscopy is scheduled, the patient will receive reminder messages about their appointment at 7 days and then 3 days before the colonoscopy procedure, and to follow the simplified pamphlet for the prep, which is the colonoscopy instructions that they will receive. Here are examples of the baseline survey along with the literacy assessed by the RAM. And these are the examples of the patient education that we created. Here to the left is a simplified instruction, simplified fit instructions, third grade reading level, along with the CRC educational pamphlet, which is fourth grade reading level, and below is the fit kit. So for the baseline survey results, 71% participant reported knowing a test to check for CRC, 82% named colonoscopy, 54% named FIT or FOBT, and 31% named Cologuard. 16% knew someone who had colon cancer. 74% reported their provider recommending CRC screening in the past, and 93% reported they would want to know if they have colorectal cancer. So I look at several questions, several of the baseline questions compared to literacy, and know anyone who has colorectal cancer. There is no significance between the limited literacy and adequate literacy, which is limited is less than 9th grade reading level, and adequate is 9th grade and above reading level. For here, heard of any test to screen for colorectal cancer by literacy, there was a significant difference showing that patients with limited literacy is less likely to know of any test to screen for colorectal cancer. There's no significance. Prior patients recommended to get screened between limited and adequate literacy. Here there were no significance shown between limited and adequate, shown between patients who were previously screened but weren't up to date with their screenings. That shows significant difference in the limited is more showing that limited patients with limited literacy was more worried or don't know how worried they were if they find out they might have colorectal cancer. And here also showing significant difference between limited and adequate, showing that the patients, limited literacy patients were unsure how worried they will get colorectal cancer some point in their lifetime. Results, it wasn't surprising that 93% of the patients selected the FIT, 364 in the intervention arm, 57% completed the FIT in enhanced usual care arm, 380 patients, which is 54% completed the FIT. For colonoscopy, there were 77% selected colonoscopy in the intervention arm, 38% completed the colonoscopy, and for 24 patients in the usual arm, enhanced usual care arm, 17% completed the colonoscopy. For the conclusion, 56% of these low-income rural patients completed their FIT screening. Simplified instruction and follow-up reminders influenced the FIT and colonoscopy completion. Scheduling screening colonoscopies has been somewhat problematic due to COVID-related issues such as healthcare workers shortages, and improved screening rates would potentially address public health disparities and improve health outcomes. That's it. Are there any questions?
Great job. I can start off with one question. I think we also have one. So the question that I had was, it's great to see that your material was written at different literacy levels. The text as well as the voicemail that was left by the providers as a reminder for the patients, were those also at like a 3rd, 4th grade reading or reading level so that patients could understand them?
Yes, it was for them to understand and remind of the motivation taxes and reminders were at fourth grade and third grade reading levels.
Great. Thank
Same
you.
as the pamphlets that we give to the patient so they could guide them as they complete their fits at home. And for the colorectal cancer prep, they could actually read and follow as they get closer to their colonoscopy date. So the do's and don'ts, what to eat, what not to eat, things like that.
I have a question.
Sure.
So colonoscopies can be kind of a stigmatizing issue. They make people uncomfortable. When you were writing, when the materials are being like created, did you think about not just like reading level, but also kind of like the framing of the procedure?
Yes, that's a lot of people, like when we're out there, a lot of people kind of, like you said, it's a stigma and they don't want to really deal with the colonoscopy. So that's why hence we had a higher percentage of people that wanted to do the fit instead of the colonoscopy. But if you do the fit and the fit comes back positive, the fit is good for 1 year. It's water-based. It's good for 1 year. And if it's positive, you still would have to do the colonoscopy. So we encourage them to know that's a potential chance of them have to do the colonoscopy. So a gastrologist could actually do the procedure and see if everything is okay, no problems.
I have a question. I don't know. Yeah, is there any strategy that you are thinking of to kind of convince more people, or I mean, even I would say increase the health literacy on how it's important to do colonoscopy tests, screening, since, as you said, it's really something that people are still kind of not used to and they refuse to. Yeah, how are you thinking to deal with these situations, so to have in the future to have more, people who are open to do the screening?
Well, when we visit the clinics, we as like some of the pamphlets that we have to improve and tell the patients more, make them more aware of colon cancer, make them more aware of the importance of early detection, and try to let them know that if it's caught early, of a potential higher chance of everything being okay. But just more awareness to the patient of the screen, even though you feel. So when I'm out there and talking to patients one-on-one, some of them will say, "Hey, I feel okay," but we let them know that you could feel okay, but you have to be screened. Let them know the importance of being screened. Even though you feel okay, you could be, So we just have to educate them more about and being more aware on colon cancer itself, and that will kind of draw them into the clinics to get screened and continue to improve screenings within the rural areas and everywhere that we're in.
Right. Thank you.
I had a question too, Joseph. Were these messages only done in English, or if not, what other languages?
Well, yes, these was done in English. One of the eligibility was the patient would have to know how to speak English and understand, because the pamphlets and everything was in English. So once the eligibility for them was to understand English writing and English itself on the whole, so they could be able to know how to communicate. So the communication we will be on the same kind of understand, the same page. So everything is in English. But even though like when I'm out there in the rural community too, we have non English speakers, but they can also, also they non-English, but can somewhat understand English, not fluently, I should say. But all the materials is in English that we have in third grade, fourth grade level. That's one of the criteria to be able to speak English.
Okay. I just have a question about the communication because it's really a big issue.
Yeah.
Let's say if you would like to include more participants in this study in the future, right? Let's say, how would you include those people that probably were excluded because of the communication barrier? Let's say maybe they didn't meet their English level to be, part of the study.
Yeah, with this, to improve, that's a great question. To improve this so that you can get the majority, more population, so it won't have like a barrier in terms of, so it won't have exclusion. We would have to have fluent language, like a research assistant, like someone who actually speaks that language. So everything will be in that language for them to follow, and also, so we'll in that type in the future, we'll have to improve in language barriers. We have to improve in the language barriers. So if we improve in language barriers, the communication will be much better in terms of screening rates.
Thank you.
That was a great presentation, and thank you so much for your time. We're gonna go ahead and continue on to the next presenter. Samantha, if you want to go ahead and introduce them.
Absolutely. So I'm so glad to introduce our next presenters. It's going to be T. Slater and Akshay Krishnan. If y'all want to share your screen.
Hello, everyone. Thank you for the introduction. My name is T, and I'm here with my co-presenter, Akshay Krishnan, and we did the digital health coaching for the residents of the Washington, D.C. metropolitan area, age 50 and above intervention, and we're going to share what we did with you. So a little background, African Americans over 50 face high rates of chronic conditions such as hypertension, heart disease, and diabetes. Digital health resources such as the patient portal or telehealth visits have been shown to be effective tools in improving the management of these chronic health conditions. However, this group of people are less likely to adopt digital health resources or DHR compared to their younger European American counterparts. And that's partially because of low digital health literacy. Digital health literacy is at the base of your ability to assess and understand health information gathered over the internet. So knowing that, our intervention was to provide in-person digital health coaching for patients in the target population on how to use DHR and improving DHL in the majority African-American wards 7 and 8 in Washington, D.C. So really just trying to help people understand how to use the resources available to them so that they can feel independently confident in using those resources. So we had two phases of the research. The first phase was the formative research, where we conducted 15 interviews of members of our target population. Our target populations are people who were active participants in the Federally Qualified Health Center, or FQHC, who were fluent in English because the coaching was conducted in English. They possess at least one device connected to the internet, and they're also either 50 years older or they had a chronic disease at any age. So what we did was we recruited participants to assess the population's understanding of DHR and identify barriers and facilitators to DHR use, and also establish segments for targeted intervention. Results were analyzed using the constructs of the health belief model and thematic analysis, and then the segments were established using various psychosocial variables. So in the second stage, the actual intervention, after we analyzed the data from the formative research, we kind of built strategies to approach people. So we recruited participants in the waiting room in the clinic or via provider, and between the months of April and August 2023. We gave them a pre-test that measured their baseline digital health literacy scores. One of them was the eHealth Literacy Scale or eHealth Scale, and the other one was the Digital Health Literacy Scale or the DHLS. Participants then received the tailored coaching based on the strategy that we selected. And then 60 to 90 days afterwards, they received a post-test where we measured their DHL again. And participants were given $80 for their completion of a coaching session and also both surveys. So the results from the interviews with the thematic analysis, there was a thematic analysis. There were three major findings. One was about the facilitators of DHR use. So those things included in-person education and technical support, strong relationships with providers, and also social support for people who around them outside of the clinic, such as their fans and family members. Perceives barriers to digital health resources included low self-efficacy and device and platform issues, especially when considering the fairly qualified health centers' security processes could be hard to navigate. And then motivations for digital health use, health resource use are perceived benefits such as cost and time saving, personal growth, meaning people felt kind of a personal responsibility to be in alignment with the trends of healthcare, and also perceived severity, meaning that people who perceive themselves to be in need of a lot of care were more likely to use digital health resources, or people envision themselves using it if they were like unable to get to the clinic because of some type of disability. These are the 4 participant segments that we discovered through the data. There are 4, I can just run through them quickly. There's current users, people who have already used it and are currently using it. And their core emotion was frustration because there's a lot of challenges using the platforms. Discontinued users, people who have used EHR in the past but stopped because they had barriers. And their core emotion is defeat because they felt that they could not actually get any benefit from it. Open potential users were people who have used DHR, who never used DHR but like to, and their core emotion was anxiety. And then resistant potential users are people who never used DHR and not interested in it, and their core emotion was apathy. So for each segment, we try to tailor the messaging and strategy to the type of to what we thought was best. For example, for people who are resistant users, we would say it is actually we would want to connect their personal needs to how DHR can help solve them.
Moving on to phase 2 for our results section. In total, we coached 132 participants. And out of those 132 participants, 64% were female, 86% were residents of Ward 7 and 8, and 97% were African American. And also 80% had self-reported a chronic illness, and the average age was 60 years old. So within those 132 participants, we spent a combined 232 hours of coaching across 2 clinic sites. And we kind of broke down here the different activities we did during the coaching sessions. So the most common activity we did was just helping patients enroll in their portal, and that was for 65% of the patients. And then for 23% of the patients, we helped them regain access to their portal if they had been locked out or needed to reset their password. And for 12%, we were either unable to log them into their portal due to some type of either not having access to their email or not having access to a phone number or some other reason, or no data was provided. And then during the coaching session, we mostly focused on these top 4 items here. So secure messaging of their provider, medication lists and refills. So being able to look at your medications at home and request a prescription refill from your home as well. And then checking for future appointments, and then how to check your lab results over time. And looking at the digital health literacy scores from pre-coaching, the average eHeal score was 27.8, and the maximum score for the best digital health literacy would have been a 40. And then the average DHLS score was 10.1, with the average and best health literacy score being a 15. And then we compared these to the post-coaching averages, which was taken when we, at the time of analysis, we were only able to reassess for 75 participants. We found that the average post-coaching eHeal score was 32.1, and the average post-coaching DHLS score was 11.4. And these differences were found to be statistically significant with a p-value of less than 0.05. And then comparing pre and post-coaching scores, 60% of participants had an increase in their eHeal score, and 47% of participants had an increase in their DHLS score. So during our assessments, we also looked at the impact coaching had on digital health resource use and attitude. We found a 25% increase in self-reported DHR use. 77% of participants would recommend coaching to their family or friends, and 85% of participants felt the coaching increased their confidence in using DHR. And we also calculated the net promoter score. And for our coaching sessions, we got a 69, which is 11 points higher than the industry average of 58. So in conclusion, in-person DHR coaching was an effective and appropriate strategy to increase digital health literacy and digital health resource use among patients over 50 or anyone with a chronic illness in the primary care setting. Additionally, DHR scope and use were not well known in the population, and even among those who had reported use, they still do not know scope very well, but the idea was generally positively received. And the population's baseline DHL scores were relatively high, which is inconsistent with the literature and the observations made by coaches in the clinic. And some recommendations that we have include a dedicated in-person digital health resource support staff at the clinic site, which is crucial for increasing DHR use, specifically for helping with enrollment and troubleshooting device issues. Additionally, trusted providers can play a key role in the introduction to and encouraging the use of DHR for their patients and also help with coaching along the way. Finally, an alternative method of digital health literacy measuring or technological savviness measuring may be needed to accurately measure the needs of patients and intervention effectiveness. And we just want to give a big thanks to Sarah Bile, the Unity Health Clinic staff, Dr. Andrew Roby, Mark Brown Bailey, and Dr. Doug Evans. Without their help, this project would not have been possible.
Thank you both so much. Excellent presentation. I just had a question. So logistically, how did this work for y'all? Was it a one-on-one session that you scheduled individually with patients, or did you have kind of a standing appointment? Or how do you kind of envision that moving forward?
So what we did basically was that we had set like office hours for the coaching, and then when people come in, if they'd had time before or after their appointments, we would talk to them and we could set up the coaching for them. I think that going forward, if the clinic kind of listens to our recommendations, they'd have like a standing person, maybe even shared amongst clinics that had set office hours that people could make appointments with to like discuss this, or even walk in if they need to. But I think that would be our recommendation.
Thank you. We also got another question in the chat. It says, how did the team deal with privacy issues and potentially being aware of health issues from the portal that the patient may not be aware of?
Yeah, so we had an IRB process that we went through, which kind of covered the members of the research team in the kind of privacy data sharing that was like included the Unity Health Clinic. So like we were all involved in like getting a HIPAA waiver and making sure that we like the patients understood that like what we were doing was kind of something that where we could see their data. Honestly, not many people seem to care, maybe because we were at the clinic, so people kind of perceived us as being employees of the clinic. But yeah, during the consenting process, we explained that we would be looking at their data and that we were like, we were compliant with IRB to make sure that privacy was followed.
Thank you. So yeah, so you didn't really experience as much of patients being hesitant about their own privacy using a patient portal, or maybe a little bit?
I feel like it was a little very, but like most people just had no idea, honestly. Like most people had they're very unfamiliar with the whole concept. So like, I mean, I think Ashley can attest to this. Like a lot of people didn't have locks on their phone, and we had to like make them get locks on their phones. So the like privacy issue it didn't really come up very much because it was just like they didn't even have the ground level understanding of the basic technology.
Thank you. We also have a comment from Valerie. Great presentation on digital health coaching. I've done this in a practice at a public computer area in a patient library at a cancer center. We had a lot of success with volunteers acting as coaches as well. And then another question, was this post-test/evaluation also conducted in the clinic, the same setting as the original eval/training, or at home or at some other place?
Some of the post-coaching was done in clinic and some of it was done via email or on the phone.
Just to follow up with that, did you find success with like via email, or was it more individuals coming in person to kind of help with the navigation?
Um, what we found the most success with was actually calling people and kind of walking them through finding the link. Or some people, I mean, like it really just depended. Some people like really just have very little digital literacy. They cannot really navigate their devices. I would say like maybe a third of people were, we kind of switched off of the being in clinic for logistic reasons. But I think about like maybe a third of people were independently able to do the survey without any prompting from us, aside from us sending the email, and everyone else we kind of either had to be in person or I had to call them on the phone and coach them through it or do the actual survey on the phone with them.
Yeah.
Any other questions? Okay, we should have some time at the end too. So if you come up with a question, feel free to put it in the chat for any of our previous presenters. But thank you both so much. Next up is going to be actually a recording of a presentation from Karen Scott. Karen is in Australia, so due to time zones, has recorded her presentation. And then can everybody see my screen okay?
Yes.
Yes.
Okay, thank you.
Hello, in this recording I'm going to talk about our study aimed at improving adolescents' digital health literacy through the development of an online education resource. My colleagues and I work at the University of Sydney in Australia, and many of us are also based at the Children's Hospital at Westmead Clinical School, also in Sydney. So, adolescence is a time of great development. Mental, physical, psychosocial, and an emerging autonomy. The internet provides a valuable resource for information and guidance, but it also poses a risk to adolescents because it does contain misinformation and disinformation that could harm adolescent health. Adolescents need a good level of digital health literacy, that is, the ability to assess the relevance of information, to appraise its trustworthiness, to understand it, and to apply it to solve a health problem. And the aim of this project was to enhance adolescents' health through enhancing their digital health literacy. This is a 3-year study run between 2020 and 2022. So the first part involved interviews and practical tasks with a range of adolescents who we recruited across Sydney and some other parts of Australia. They filled in a demographic survey and the eHeals self-assessment of digital health literacy. They undertook a search and appraisal task to solve a health scenario that we gave them. And then we interviewed them to find out about their use of online health information and their digital health literacy. We analysed the results and we found that adolescents have a reasonable functional health literacy, so they do understand information that's aimed at consumers, particularly adolescents, though they struggle with information aimed at health professionals. They can use information to solve a health problem, though usually in consultation with their parents, often their mother. Adolescents had a weaker critical health literacy, so that is the ability to determine the trustworthiness of online health information. Sometimes they had learnt skills at school relevant for research on the internet, but they generally knew about some skills, but they didn't actually apply them in the practical tasks. So we identified this as an area that we really wanted to focus on in developing an education resource to help adolescents. So the next stage in 2021 was co-design. So we ran 3 co-design workshops with a range of adolescents. And we further explored their use of online health information and social media and the web, and also their digital health literacy. We also asked the adolescents to tell us what they would like in an education resource aimed at them to help them improve the ability to identify trustworthy health information. So in particular, they wanted a game or quiz-based some sort of education resource. They strongly recommended use of video and short videos, so ideally less than 1 minute, 1.5 at the most. In particular, the TikTok style or the YouTube style was recommended. And they highly recommended making it for a mobile phone or an iPad, but particularly mobile phone friendly. So we created 3 storylines based on the adolescents' ideas that integrated all of the ideas that they recommended. So there were branching areas in the storyline where the users had to make a decision about which way to go. There were a lot of videos, TikTok style or YouTube style, and quizzes for adolescents to test their skills or to further practice them. All of the quizzes had feedback so that to explain how adolescents could potentially improve their digital health literacy skills. And finally, the storylines ended with an expert video highlighting the take-home messages about particular skills. So this is what the app looks like, yeah, so it was a lot of fun making it. So we recruited a fresh sample of adolescents who completed the same demographic and eHeals surveys. They did a similar search and appraisal task. There were 2 clinical scenarios, so half did one of those and half did the other. Then they used the app, which usually took about 10 minutes. And when adolescents used one storyline, they were certainly encouraged to go back and, because it was branching, to use the branch that they hadn't followed the first time round. So after that, they completed a search and appraisal task again, using the clinical scenario that they didn't have in the first time round. Then they completed the eHeals and finally an evaluation survey. So adolescents reported that after using the app that they had a better digital health literacy, and we observed that they chose better quality websites. We found that the adolescents were using more heuristics to identify trustworthy online health information, such as using government and health websites and looking at who the authors were and the date of the source. They also cross-checked information with more than one site, and they spent more time searching and looking for information that was relevant and trustworthy. The adolescents also used less poor digital health literacy skills, so they were less inclined to rely solely on one source of information and less inclined to solely rely on Google suggestions and snippets. And finally, we found that there was a change in the type of website that the adolescents looked at first time around, comparing before and after using the app. So before using the app, over half of the participants really used the Google search engine pop-up or suggestion for health information. And after using the intervention, they were more discerning in going through the Google search results page to identify sites that appeared to be from government or a health organisation. There were instances where adolescents chose websites when they were looking to cross-check information. Sometimes they chose websites that weren't trustworthy, but they got out of them pretty quickly once they identified that they weren't trustworthy. We also found the adolescents liked using the app, and the main suggestion for improvement was to make it a bit more challenging for those who were more capable at using it. So, in conclusion, the app that we used was effective at helping adolescents improve their critical health literacy, so they were better at discerning trustworthy health information. They learnt to use some of the heuristics that would help them to identify trustworthiness, and so and you know, some of the language as well, just through using the app, some of the language in that functional health literacy also improved, so knowing author qualifications, for example. But we still identify that there is room to improve or to expand on helping adolescents improve their critical health literacy. So next month we're going to run some more co-design workshops with adolescents to help us co-design new storylines, which will be running out next year in another evaluation. And I'd like to thank my co-investigators and also our research assistant and research students, who were all young people and contributed greatly to the project and in their interactions with our participants. So thank you.
And a big thank you to Karen, who could not be here today, but I loved her presentation, and the idea of designing something with young people is super important. So absolutely loved that. Any other questions for any of our other panelists? I think there was one that we might have gotten to missed right before we switched from Alex. I think this is for Tian Akshay. Was this post-test / evaluation also? Oh, no. You might have already have plans for this, but it would be awesome to do another follow-up. Okay, I think that's the only message we missed. So I think we addressed that one. Anything else, y'all? Any last burning questions? If not, thank you so much to all of our presenters. Thank you all for your time, your attention today, and your great questions. Oh, and thank you to all the presenters. Yep.
The next session should be starting around 4:30. You have different workshops that you can attend, but thank you all for joining today.